it wouldn't be fair to lead you to believe that only viruses are the only microbes that cause cancer. A very, very specific bacteria does as well, and our knowledge about it is growing by leaps and bounds. And it's the same bacteria that causes duodenal and stomach ulcers and stomach inflammation, Helicobacter pylori. Helicobacter pylori causes, it's not a factor, it causes 100% of all gastric lymphomas. These are called maltomas because the lymphoid tissue is mucosal associated. So the lymphomas of the lymphoid tissue, which is around the mucosa of the GI tract and other places, are called maltomas. And also, it has been strongly indicted in epithelial malignancies or gastric adenocarcinomas as well. So it would not be fair if you thought viruses were the only things that cause cancer. This is like the classical prototype of a bacteria. Let's talk about the good guys now. Up until now, we talked about the bad guys, the cancer cells. Let's talk about our body. Let's talk about what it does to fight and maintain and destroy. And basically, you have to understand the concept of immune surveillance. And immune surveillance is related to the fact that when our body sees cells, cancer cells, potential cancer cells, that is not recognized as part of the MHC system, it destroys them. And the main tumor cell, the main cell to attack and destroy tumors directly are the CD8 T cells. These are, so when you see a tumor under a microscope and it looks like it's causing a lot of inflammation, you see a lot of lymphocytes around it, most likely those are CD8 plus T cells attacking the tumor directly because it has been recognized that these cells should be attacked. In the case of NK cells, for example, it attacks the cells even if it hasn't recognized them. Once again, it was like Rodney Dangerfield's football buddies. After it attacked a quarterback, it went after his family. I mean, they're very non-specific killers, as well as our usual gang of macrophages, which are chewing up the fragments, and antibodies as well. So if you want to think of these four items here as the main players in the immune surveillance system, you certainly can. And if you want to think of it graphically, if you want to think that the normal cell is protected from a T cell because all of its antigens are recognized, it's therefore going to be left alone. You could think of that. But if you have an oncogene which produces an oncoprotein which normally is not recognized, that will be attacked by a T cell, or hopefully will be attacked by a T cell. On the other hand, you could have a mutated self-protein or an overexpressed self-protein being attacked by a T cell for the same reason. You can have an oncogenic virus which can be attacked before, during, or after it's doing its thing inside the cell. So the general concept is, if cells are altered through this process of what we call transformation, they may and should be, and often are, recognized as antigenic bad guys, and therefore will be attacked by the CD8 plus T lymphocytes. And these are the main cells, which are the main eliminators of tumor cells. But getting back to the bad guys again, they do a whole wide variety of tricks which may cause problems with immune surveillance. And the one thing they do is mutate. So if cells are normally being attacked, they can mutate in order to survive so as not to be attacked. It's all part of, evolution. You might have a tumor cell which has a decrease in MHC molecules on its surface and therefore less likely to be attacked as well. That's another mechanism. Also, there's the concept of co-stimulation molecules. As you know, in order for T cells to attack, they not only need antigens, but they need co-stimulation molecules. If there's a lack of them, you may have decreased immune surveillance. immunosuppressive agents weaken any process, including immune surveillance. The antigen expressions on tumor cells may be masked by other compounds and therefore escape immune surveillance by that mechanism as well. And last but not least, you may have a process by which the cytotoxic T cells are triggered off to be apoptotic and therefore not present in enough strength or enough amounts to do immune surveillance. These are all 6 common mechanisms by which tumor cells can escape immune surveillance, and I hope I explained them clearly enough. Another thing to remember is that once you have a tumor, a detectable tumor, an anatomic lesion, this lesion is growing. It will encroach, it will invade, it will put pressure on, it will destroy, it will infiltrate its neighbors. So a good knowledge of anatomy in terms of what is close to what would be a predictable prototype for what a tumor is going to do as it encroaches upon its neighbor. A tumor may also produce hormones and cause a physiologic syndrome. A tumor, in the process of destroying a blood vessel or weakening a mucosal surface by virtue of destroying a mucosal surface, may result in bleeding and infection as well. These symptoms may be quite acute as well. If a tumor ruptures an organ or it infarcts an organ, you can have a very acute syndrome or symptom acutely as well. And once again, if the tumor is at the point where it's metastatic, this metastatic lesion can once again do all the same things anatomically and physiologically that its apparent blob of tumor cells did as well. Another general symptom of widespread tumor is the concept of cachexia. Normally, when you have a reduced diet, you lose fat much more so than you would lose muscle. But in cachexia, there is a greater proportion to muscle loss with regards to fat. And we know that there are factors like tumor necrosis factor, which when they are doing their job, destroy tissues and result in cachexia. Interleukin-1s can do exactly the same thing. In addition, another factor called PIF, or proteolysis inducing factor, is expressed in greater amounts and activated in malignancies, and this has a similar effect of producing proteolysis. So these are some of the biochemical mechanisms to explain cachexia. Another concept is that of a paraneoplastic syndrome. A paraneoplastic syndrome is defined as a syndrome secondary to a tumor, but not necessarily because of its direct anatomic or physiologic effect. And the most obvious type of paraneoplastic syndrome would be a endocrinopathy, or a tumor which produces excessive amounts of an endocrine hormone, resulting in an endocrine-like syndrome, like Cushing's syndrome, for example. A lot of the nerve and muscle degenerative disorders, like myasthenia, seen with lung cancer, can be regarded as a paraneoplastic syndrome. Skin conditions like acanthosis nigricans or dermatomyositis, these are often seen in malignancies, but not necessarily because of the direct effect of the malignancies. HPOA, or a hypertrophic pulmonary osteoarthropathy, overgrowth of the joint, seen with a lot of cancers, lung cancers. Vascular syndromes like Trousseau's syndrome or migratory thrombophlebitis or tumor endocarditis are seen as a paraneoplastic syndromes. Anemias are present almost universally in widespread malignancies as a hematologic paraneoplastic syndrome. And last but not least, we will learn that nephrotic syndromes can be due to a wide variety of renal diseases, but they can also be seen in general malignancies as well, independent of primary renal pathologies. So this is generally the family of paraneoplastic syndromes, and we're going to talk about the big one first, endocrine. I thank you very much.